Good afternoon.
Complete. We'll complete the lecture we started the other time. That's on the clinical approach to a patient with heart disease. Before we move on to taking the lecture on biventricular heart failure. So I'm trying to share the slide. Okay. Can we see the screen? Yeah, it's up now. So we had gone through a good chunk of it. So I think we had talked about blood pressure, JVP, and we're about this point, talking about the examination of the precordium. And so the examination of the precordium starts with inspection. Thank you. Oh, okay. Okay, so we're talking about precordium. So examination of precordium, the patient should be well rested at 45 degrees, the adequately exposed, no shirts on. At the mid-clavicular line in normal cases. That's when there is no cardiac pathology. The left ventricular dilatation will displace the apex downward and laterally. It may be impalpable in patients with emphysema, obesity, or pericardial or pleural effusion. Okay, so there are various characters of the apex that one can notice. You can have a tapping apex. That is a palpable first sound, and this occurs in in mitral stenosis. You could also have a vigorous apex, which may be present in diseases with volume overload, like aortic regurgitation. We could also have a heaving apex, where the apex is lifts the hand. You know, the finger of the hand on examination. This is usually a sign of left ventricular hypertrophy, and you can see this in aortic stenosis, systemic hypertension, hypertrophic cardiomyopathy. Also, you could have a double apical impulse, which may occur in hypertrophic cardiomyopathy. Also, there's sustained left parasternal heave, which occurs in right ventricular hypertrophy or left atrial enlargement. A palpable trill may be felt over an abnormal cardiac valve. A trill is a palpable murmur. It's usually felt as a cat scratch on the hand. The example is a systolic trill with aortic stenosis. Usually indicates that if the patient has regurgitation, that this is usually from a primary valve disease. So we move to auscultation. After you inspect, you palpate, the next thing you do is to auscultate. Auscultation is done with either the bell or the diaphragm. The diaphragm is the one that has a thin membrane over the head of the stethoscope, while the bell is the one without the membrane. The bell of the stethoscope is used for low pitch sounds like mid-diastolic murmurs, added heart sounds like the fourth heart sound, third heart sound. And the diaphragm is used for high pitch sounds like systolic murmurs, aortic regurgitation, ejection clicks, and opening snaps, and also for the first and second heart sounds. So the areas of auscultation are shown below. So usually you want to auscultate over the apex, which is where the mitral valve is located. We mentioned before that the apex is usually located at the intercostal space, lateral to the mid-clavicular line. Also, you could have the tricuspid area, which is usually located at the fourth intercostal space at the left external area. You could also have the pulmonary area, which is located at the second intercostal space. Can you see my cursor? Where is marked P?
Yes, we can see.
Yeah. The pulmonary area is at the second intercostal space at the left sternal border, while the aortic area is located at the second intercostal space at the right parasternal border. Okay, so there are other areas of auscultation where you can hear, like for instance, this is what they call the second aortic area, where you can hear the aortic regurgitation more clearly. And that is usually at the third intercostal space, the left sternal border. It's called the second aortic area or the EBS area. All right, so the other things we need to know about auscultation is that usually you have commonly the first and second heart sound. The first heart sound is caused by the closure of the atrioventricular valves as a mitral and tricuspid valve, while the second heart sound is caused by the closure of the pulmonary and the aortic valves. Okay, so other added heart sounds you could hear are the fourth heart sound and then the third heart sound. Fourth heart sound usually comes before the first heart sound. It is usually caused by a forceful contraction of the frontal contraction of the atrium against a non-compliant ventricle. So it's seen in conditions like hypertensive heart disease, where the ventricle is hypertrophied and stiff. Can also be seen as a normal finding in elderly people where their diastolic function have reduced. So that's the fourth heart sound. So if we usually write it as fourth, first, and second, if there's a fourth heart sound. Also, you could have a third heart sound, which is caused by rapid filling of the ventricles. This is usually seen in conditions like heart failure or anemia. Okay, so these are some of the heart sounds that are possible. Okay, and usually we write it as first, second, and third because it comes after the closure of the second heart valve when the ventricles start to fill. All right, so some investigations we usually do for cardiac patients would include things like blood test, usually your routine hematology test. Your routine hematology test, which may include like anemia, and recently they have begun to link iron deficiency with cardiac failure. maybe. Also, your serum creatinine electrolytes are very important in cardiac patients. You want to know the kidney functions, like in hypertensive patients. A lot of times you could have renal congestion. Okay. Also, cardiac enzymes like troponin, creatinine kinase, aspartate, aminotransferase, lactate dehydrogenase will also be important in patients with myocardial infarction. Thyroid function test is also important. Your investigation of hypertensive to cause heart failure in certain patients and patients with tachycardia. Then the brain natriuretic peptide can also be diagnostic for heart failure, and it can help differentiate if a patient with breathlessness has breathlessness from a cardiac origin or a pulmonary origin. So if it's elevated, it's likely to be from a cardiac origin. Chest X-ray is a very basic investigation that is very important for investigation of cardiac diseases. It can show you the cardiac silhouette and also can help to rule out differentials from the lungs or precipitating diseases in the lungs. So you have things like, the ideal thing to do is to posterior anterior X-ray. That is, the patient has his chest on the film board and the you can see the right ventricle, which is more anteriorly placed. And then you have the right atrium, and you can see the great vessels, see the aorta. So one should have this picture in mind when viewing a chest X-ray. There's an X-ray showing a bulge on the left aspect of the upper left aspect, which is around the area where you have the left atrium. And you can see another, this side is also bulging. So it's trying to point to biatrial enlargement. So this is left atrial enlargement. This is showing right atrial enlargement. Neutralization of the left heart border. So other investigations you could do is the ECG, what we call electrocardiography. It can show you the electrical activity of the heart, which is printed as a graph. You can use it to determine the rate, the rhythm, and chamber size hypertrophy. It can also be used to say whether there are electrolyte abnormalities. Can also be used to detect presence of myocardial infarction, where you see changes in the ST segment. This is just shows the waves on the ECG. You have the first wave represents atrial depolarization as a P wave, and then you have a downward deflection, which from year to year represents ventricular depolarization. And then this is so the Q wave, the R, and the S. So the first downward deflection after the R interval is called the Q wave. So this is the Q wave. From here to here is the Q wave. Then the next upward deflection after the Q wave is called the R wave, and the next downward deflection is called the S wave. Then you have the ST segment, because after the S wave, the next deflection is the T wave. So you have the ST segment. So it's not, that is how it is. You don't have to work it out. You just have to know all these waves to be able to decipher or read an ECG. The U wave comes after the T wave. It's not often seen. It's seen in a few conditions like hypokalemia. Okay, so and after this cycle, the cycle starts again from a P wave, then it will go to another Q, R, S, T. So that's just basically, it has waves and intervals, and it's very useful for investigating cardiac diseases. These are some of the normal values of the ECG intervals. Maybe if we have time and if it's relevant, we may look more at the ECG. So there are other forms of ECG that can be helpful. One could do a 24 hours ambulatory ECG, what they call Halter Monitor. Okay, and this is done for patients that have frequent arrhythmias, people that have bradycardia or syncope. Because you're thinking probably what's causing it. You put on the ECG on the patient's arm and connect it to the chest. Usually the patient can wear this ECG for 24 hours, 48 hours, and then you get your readings back. When the patient comes back, you plug the machine to the computer, and you can see the tracings over the next over the last 24 or 48 hours, depending on your programming. Then also you have event recorders. So these ones can be there for up to 7 days, can record the electrical activity of the heart in the ECG pattern for up to 7 days. They are usually also very useful when the arrhythmias are not occurring on daily basis. Some even record for up to a month. So echocardiography is also a very useful tool in investigating heart cardiac patients. It's a non-invasive diagnostic technique that is widely employed in clinical cardiology. It involves the use of ultrasound to assess cardiac structure and function. Usually, a physician or a technician performs the study and usually will take about 15 to 45 minutes. You can see the function of the heart. One of the most important parameters on echo is the left ventricular ejection fraction, which the normal is usually 50 and above. Okay, so that is echo. You can also tell you whether the patient has hypertensive heart disease. It can measure the diastolic function of the heart, can give you the stroke volume. So it's very important tool we use in cardiology. You can also image the aorta too. Usually there are two major forms, the transthoracic echo, that's what we talk about, the TT, Transthoracic Echocardiography, which is done in most places, the more common form. And then we have a transesophageal echo. Some people refer to it as TEE. Okay, so this transesophageal echo. It's also very important for assessing patients with valvular heart disease, and then for patients with atrial fibrillation, you want to use a transesophageal echo to look at the left atrial appendage to exclude the presence of a thrombus before cardioversion. Other investigations that are important, the CT, the cardiac CT. You can use it for coronary artery check for coronary artery calcification, and also you could do a CT coronary angiography where you can visualize the coronary circulation, the blood vessels that supply the heart. This can help you to rule out an MI, a myocardial infarction, or if those vessels are diseased. So also the use of cardiac magnetic resonance, not very common in our environment yet, but it could also provide useful information about the heart where echo is not sufficient, okay? And so cardiac externalization is use of an radio-opaque catheter passing through the femoral vessels into the right side of the heart. And then you can use it to measure the pressures in the heart, especially for patients with pulmonary hypertension. And also you could use it to inject dyes that would apply the blood supply to the heart. It can also be used to intervene in patients that have diseased coronary arteries that are stenosed or occluded. You use for stenting and all that. So it's usually done in a cath lab. Yeah. Okay, so that's that for the approach to patients with heart disease. Any questions, or do we move to the next lecture on heart failure?
The next lecture, please.
All right. Okay, so. Okay, so biventricular. Okay. So, Dr. Isaac, are you still with us? Still all Tantaba?
Yes, sir.
Okay. Failure. So, all right. So heart failure is not moving. Okay. All right. Sorry. So this is the outline we'll be using to discuss. All right. We do the introduction, epidemiology, etiology, pathogenesis, and clinical features. So heart failure is a complex syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the heart to function as a pump to support a physiological circulation. Okay, so basically what it's saying is that complex syndrome means that it's a constellation of signs and symptoms. So that's a syndrome means constellation of signs and symptoms. And what will cause this signs and symptoms is usually as a result of a structural or a functional cardiac disorder. So either there's a problem with the structure of the heart or its function. And this would affect the ability of the heart to pump blood to the circulation. And we know the blood carries nutrients, it carries oxygen to all the cells and all the organs of the body. So that's just basically what heart failure is talking about, a failure of the pump of the heart as a result of the problem with the structure or the function, and it will lead to signs and symptoms. But the European Society of Cardiology also has its own definition. And the diagnosis of heart failure requires presence of typical symptoms and signs, such as dyspnea, peripheral edema, respectively, and also objective evidence of structural abnormality and functional abnormality at rest. Worldwide, the incidence of heart failure is variable, but increases with advancing age, and approximately 26 million people have been affected with heart failure. In the UK, overall incidence is about 2 in 1,000. The prognosis of heart failure has improved over the past 10 years with evidence-based therapy. But the mortality rate remains high, and approximately 50% of patients are dead at about 5 years. So the incidence of heart failure has been on the increase. Why? Because of the advancement in healthcare. People are getting better healthcare and living longer. And the longer they live, the longer there is time for risk factors to cause complications in them. So heart failure is like an endpoint of cardiovascular disease. We usually say that heart failure is not a diagnosis in itself, but it's like an endpoint. So most times when we put the diagnosis of heart failure, we say it's secondary to hypertensive heart disease, secondary to whatever is causing it. So it's the leading cause of death of medical hospital admissions in over 65-year-olds, and it accounts for 5% of admissions to hospital medical wards. And the cost of managing heart failure in the UK exceeds about £1 billion per year. Where they have insurance, they know how much they pump into it. So coronary heart disease is the most common cause of heart failure in the Western countries. In our own environment, the studies have shown that it is hypertensive heart disease. So heart failure has shown a worldwide prevalence of 64.34 million cases. And we have said that because of increase in the aging population, the incidence is rising, and better control of communicable disease in developed countries. People that would otherwise have died from infections will survive to have some of these non-communicable diseases. And then better survival from ischemic heart disease in developed economies, and more efficacious treatments of cardiovascular diseases. And it's the single most costly medical syndrome. So usually the causes are quite many, but the most common cause in our own environment is hypertension. Like I said, hypertensive heart disease is the commonest cause in our environment. Also, you could have things like cardiomyopathy, which is also quite common in our environment. And then ischemic heart disease also can cause it. We have quite a few of that, but most of our patients either have hypertension or cardiomyopathy. So it's important to note that. So these figures are more for Caucasians. So in our environment, hypertension is the chief cause. Other causes include cardiomyopathy, either hypertrophic or restrictive cardiomyopathy, or amyloidosis like sarcoidosis. Also valvular heart diseases like mitral, aortic, or tricuspid. Congenital heart diseases like the atrial septal defect, ventricular septal defect. Alcohol and drugs, also chemotherapy, trastuzumab, imatinib, also hyperdynamic circulation. Hyperdynamic circulation, things like anemia, thyrotoxicosis, hemochromatosis, Paget disease also have been implicated in the etiology. Right heart failure can cause right ventricular infarct, pulmonary hypertension, pulmonary embolism, chronic obstructive pulmonary disease. There's what they call ventricular codominance. If one part of the heart fails, the other would likely fail because they have some dependence on themselves. So if the right heart fails, the left heart may fail. Or the things listed in bracket there are actually some causes of right-sided heart failure. Okay, so ventricular codominance could cause be a reason why the right heart will fail and the left heart will fail. And it's what is of note to mention that the most common cause of left ventricular failure, most common cause of right ventricular failure is left ventricular failure. Usually when the left heart fails, it will affect the right side of the heart. So arrhythmias like atrial fibrillation could also cause and precipitate heart failure. Bradycardia also, like complete heart block, sixth sinus syndrome, could also cause heart failure. Pericardial diseases, constrictive pericarditis, pericardial effusion, infections, also myocarditis and Chagas disease. Okay, so how does the heart fail? What is the pathophysiologic mechanism? Usually, one of the measures of the function of the heart is the cardiac output. That's how much blood is pumped into the circulation, and it's essential to heart failure initiation and propagation. So if the cardiac output is low, that means you may not get enough perfusion of the organ systems. And so what are the things that will cause low cardiac output? Those are the things we have mentioned ab initio. And these things will do it by either reducing the systolic function of the heart, as the heart will not be able to pump blood adequately, or affecting the diastolic function of the heart will not be able to receive enough blood. So if it doesn't receive enough blood, it cannot pump out enough blood. And the first response of the heart will be an attempt to compensate. We want to compensate for this reduced compensatory mechanisms, like increasing the afterload. Afterload is the resistance the heart has to pump against to get blood to the body. We can also increase the preload. Preload is the amount of blood left in the heart after diastole, just before systole. So if there's enough blood returning to the heart, then there will be more blood being pumped out. And also the cardiac contractility also could increase. The force of contraction of the heart will increase. And the cardiac output can be calculated as stroke volume times the heart rate. Stroke volume is the volume of blood pumped out of the heart for each cycle, and the heart rate is just the number of times the heart pumps in a minute. So this can give you the cardiac output. So that's just literally looking at it as the volume pumped out in a minute, basically. So if the heart rate is faster, more volume will be pumped out in a minute. And then if the volume that is pumped out for 1 beat, the stroke volume is one higher, so the cardiac output also will be higher. So the heart usually will try to compensate by increasing the stroke volume and the heart rate, and various mechanisms will come to play. There will be activation of the sympathetic nervous system, the renin-angiotensin system. We'll talk more about that as we go on. Okay, so the preload, this talks about the initial length of fiber at the end of diastole. So the volume of blood that returns to the heart will determine the stretch on the ventricular muscles. So if you have more blood coming into the heart, the heart will be stretched to a larger extent, and the end diastolic proportion to the left ventricular end diastolic volume in the left ventricle will be increased. Okay, so that's one of the things that the body tries to do. It tries to increase the return of blood to the heart by causing vasoconstriction. Okay, so preload would increase in patients that have heart failure. Contractility will also increase, as this may be by increase of sympathetic nervous system releasing noradrenaline and adrenaline to increase the force of contraction of the heart. Then the resistance to ventricular ejection fraction will also increase. These other mechanisms that can cause vasoconstriction, like activation of the renin-aldosterone angiotensin system. One of the ways preload is increased is through the effect of aldosterone and kidney causing salt and water retention. That will increase volume in circulation. That helps increase preload. And then the angiotensin 2, which is produced by the action of renin on angiotensin converting enzyme, would cause vasoconstriction. That would increase the afterload. So it's a complex network of activities. So of note is that, so when all these compensatory mechanisms fail, that's when the heart symptoms of heart failure will now show up. So there could be, we said there's activation of when the heart starts to, when there's reduced cardiac output, there'll be activation of the sympathetic nervous system. That will be to increase the heart rate and to increase the force of contraction. Also, you have the activation of the renin-angiotensin aldosterone system because of reduced perfusion of the kidneys. Because of reduced perfusion of the kidneys, there'll be activation of renin-angiotensin system. There'll be lead to increase preload. Also, you have endothelin. Endothelin would also, more endothelin will release. This causes potent vasoconstriction. And also other cytokines also will be released. Ultimately, all this would lead to also the stretch in the myocardium could lead to the release of atrial natriuretic peptide and brain natriuretic peptide, which are agents that would cause natriuresis. Natriuresis means they would cause loss of sodium in urine. This would also be followed by diuresis. They also cause vasodilatation in a bid to reduce the afterload, and also they can inhibit the action of the renin-angiotensin system. So it's also compensatory mechanisms that come up. They also, you have, because of the release of some of the renin-angiotensin system also leads to production of angiotensin 2, vasoconstriction would ensue. So this calling to also cause increased vasoconstriction. And then some of the, ultimately these mechanisms, some of them, like the noradrenaline and all those things released by the sympathetic nervous system are toxic to the myocytes. And this can lead to death of the myocyte, lead to apoptosis, replacement of the heart muscles with fibrous tissue, and ultimately failure of the heart. Okay, so we said these things could be myotoxic. So this will lead to death of the myocytes. The heart will attempt to heal by fibrosis. It will become dilated, and we would have heart failure symptoms. Okay, so what are some of the symptoms we will have in heart failure? Breathlessness. Usually the breathlessness usually progressive, starts on mild exertion, progresses to breathlessness at rest. Patients could have orthopnea, and the orthopnea simply means that the patients become breathless when they lie down in the recumbent position. Then also they could have paroxysmal nocturnal dyspnea, which occurs when the patient is sleeping. And we said the other day that it is usually worse than orthopnea because so it will have gathered in the lungs before the patient wakes up. So usually it's typically described as patient that was sleeping and suddenly wakes up. breathless and has to rush to get ventilation probably from the window. Also, they could be cough. Cough is usually worsened when the patient lies down, usually productive of frothy sputum, could be blood-stained or pinkish because of capillary rupture. Also, they could have leg swelling. We mentioned that we could have increased hydrostatic pressure from salt and water retention, vasoconstriction. So when you have increased hydrostatic pressure, it could lead to fluid seeping into the interstitium. That's what causes even the pulmonary edema that leads to the orthopnea and PND. So this would also be responsible for the peripheral edema, leg swelling that the patients come in when there's increased hydrostatic pressure and blood seeping into the interstitium. Also, they could have chest pain if myocardial infarction is what is central to the etiology of the heart disease. And also they could have palpitations if there are other coexisting arrhythmias. Okay, so some features we can see on a lot of times they will be seated up and they can hardly walk properly without becoming breathless. They will be pale, jaundiced, we have pedal edema, and sometimes in some cases they will further examination specific to the cardiovascular system. When you check their pulse, it could be, usually they will have a tachycardia. And tachycardia from heart failure is usually up to 120 beats per minute. You could also have, so you check the volume, could be small volume. And then in some cases, we talked about the hyperdynamic causes of heart failure, like thyrotoxicosis, wet beriberi, aortic regurgitation, anemia. So in such cases, they would have a bounding pulse. But most of our heart failure patients come with small volume pulse, and they will have a tachycardia of up to 120 beats per minute. There's also the blood pressure may be elevated in some patients, but often they come with normal or low blood pressure. They could have raised jocular venous pressure, and they could have an active precordium. Also, they can have a displaced apex. We had mentioned before that the character of the apex is very important. If it's displaced and heaving, you'll be thinking of hypertensive heart disease. If it's displaced but diffused means you can feel the apex over two intercostal spaces. So in such case, you'll be thinking of a dilated cardiomyopathy. Then for when you auscultate, one of the most important findings is that you get a gallop rhythm. Gallop rhythm means that you have tachycardia, that is heart rate greater than 100 beats per minute, and a hardened heart sound. In heart failure, what you are expecting is a third heart sound. Okay, but in some cases, you will hear a fourth heart sound. But usually you will have a gallop rhythm in patients with heart failure. And you could also hear cardiac murmurs, depending on if it's a valvular heart disease involved or if the heart is dilated and you have functional murmurs. Okay, so this is still just a summary of the clinical features. The New York Heart Association classification of heart failure is very important. Also, it helps you to from the patient. No limitation. It has normal physical exercise. Normal physical exercise does not cause fatigue, dyspnea, or palpitations. Class 2, the patient has mild limitation. Is comfortable at rest, but normal physical activity produces fatigue, dyspnea, or palpitations. And class 3, marked limitation. Patient is comfortable at rest, but gentle physical activity produces marked symptoms of heart failure. And in class 4, symptoms of heart failure occur at rest and are exacerbated by any physical activity. Well, the easier way to remember is that for class 1, there's no limitation of activity. Class 2, there's mild limitation of activity, or patient has dyspnea on moderate exertion. And then for class 3, there's marked limitation of activity. Patient has dyspnea on mild exertion. While class 4, the patient has dyspnea at rest. Okay, so these are some other things we should take note. The precipitants of heart failure. Things like anemia could precipitate heart failure, infections. So usually when we have patients with heart failure, you want to know what is precipitating it. So infections could be one of them. Urinary tract infection, chest infections, even malaria. Underwent stressful conditions like surgeries. Then people that are given some IV infusion. Also, things like valvular heart disease could precipitate heart failure. Ischemic heart disease could precipitate heart failure. Arrhythmias like atrial fibrillation can precipitate heart failure. Even bradyarrhythmias can precipitate heart failure. Okay, so when you see a heart failure patient, you've taken your history. Part of what you're expected to do is tell what is precipitating this heart failure. Poor drug compliance, especially in patients that are stable and have started treatment before. A lot of them, they have not been counseled properly not to stop their drugs, or some are depressed. So this could cause precipitate heart failure. Also, you need to look out for the poor prognostic features of heart failure. One of the common ones is high stage 4. Those are some of the things that could predict poor outcome. Yeah, a lot of them, can check them up. Then you have clinical syndromes of heart failure. Okay, so now heart failure could, I mentioned before that it could be as a result of the heart not pumping the blood well, reduced systolic function, or it could be as a result of the heart not blood well. We'll talk about reduced diastolic function. Okay, so we could have systolic heart failure with reduced ejection fraction. When the ejection, when you do an echocardiography and ejection fraction is less than 50%. We could also have heart failure with mildly reduced ejection fraction. When you do an echocardiography, patient has heart failure, and you do an echocardiography, and then you have the blood pressure, the ejection fraction between 40 to 49. That's called heart failure with mildly reduced ejection fraction. Okay, and then if the ejection fraction is less than 40, that's heart failure with reduced ejection fraction. So I'll take that again. I think I didn't clearly define it. So we said heart failure with reduced ejection fraction is when the ejection fraction is less than 40%. Okay, then if you have ejection fraction between 40 and 49%, that's heart failure with mildly reduced ejection fraction. So patients that have heart failure with an ejection fraction of 50%, they are described as having heart failure with preserved ejection fraction. Okay, and these patients, yes, how would you diagnose them? The ones with preserved ejection fraction, they will come with typical symptoms of heart failure. When you do an echocardiography, you will find features suggestive of diastolic function, and they will have normal ejection fraction. And then if you do a BMP or NT-proBNP, they will be elevated, markedly elevated. So that's how we identify these patients with preserved ejection fraction. All right, other important investigations for heart failure are the chest X-ray, which will show what we call the ABCD of heart failure, where you have A for alveolar edema, B for battering appearance, C for cardiomegaly, D for upper lobe diversion, and then E for effusion. Okay, sorry, B, I think B is for Kelly B lines, okay? Upper lobe diversion refers to a feature of pulmonary edema. So B is for Kelly B lines. Okay, so those are the things you see on heart failure. The chest X-ray can actually be diagnostic for heart failure when you see all these features. So the ECG is also very important. Whether there's a tachycardia, whether there are arrhythmias like atrial fibrillation, or whether there are ventricular tachycardias complicating the heart failure. So the ECG is very important investigation. It can also show chamber dilatation enlargement. And it is often said that if you have a normal ECG, it can rule out heart failure. Okay, so if you have a normal ECG, the patient is unlikely to have heart failure. Also, you could do a transthoracic echocardiography, which would help us to categorize heart failure as either heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, or heart failure with preserved ejection fraction. So it could show whether they have valvular lesions. It could show whether they are dilated heart chambers. It could show the function of the left ventricle, of the right ventricle. So it's one of the key investigation, or for me the most key in diagnosing heart failure where it is available. Okay, the other things that we could do are blood tests, the brain natriuretic peptide, the EUCR. EUCR is particularly very important in heart failure patients because diuretics like furosemide could cause hypokalemia. So patients are on furosemide without potassium-sparing diuretics can go into hypokalemia. They could have hyponatremia. But if then patients on potassium-sparing diuretics like the aldactone, they could have hyperkalemia. Even the ARBs and ACIs have also been known to cause hyperkalemia. So it's very important. I think there's an error here. This is supposed to be FBC, full blood count. We talked about infections precipitating heart failure. So to rule out infection, also the PCV, if there is anemia, could precipitate heart failure or even cause anemic heart failure. And then urinalysis need to rule out other things like infections and renal impairment. So it's important to have some of these investigations. For patients that have heart failure being caused by MI or precipitated by MI, it's good to have a CT coronary angiography done. This may show clearly what the lesion is. And then for patient with, CT coronary angiography is important in climes where they have resources to do it for most of their heart failure patients. It could help point out whether the coronaries also have, whether they're also diseased. And then it's done for patients that have been worked up for other cardiac surgeries. Well, most times, if you're trying to look at the coronaries, you want to do coronary angiography in the cath lab. So this you can use to even intervene in patients that have ischemic heart disease. Okay, so for treatment could be non-pharmacological. The non-pharmacological treatment would include putting the patient in a cardiac position at 5 degrees, or even sitting up, depending on how they present. We want to also restrict their dietary intake of salt to 2 grams a day. Also, when they are more stable, you want to recommend exercise and DASH diet for them. So that's diet that is low in carbohydrate and rich in vegetables. You want to remove things like red meat from their diet. They could take chicken without the skin, and then eat a lot of fruits and vegetables. So diet is also very important. And then also when they are more stable, they could do what we call graded exercise. That is, they are allowed to exercise, but not to do things that are very stressful, okay? Okay, so pharmacological treatment of heart failure, especially for patients that are presenting with acute heart failure. First of all, we said you want to put them in a cardiac position or seated up. And then if the oxygen saturation is less than 90%, you want to start them on oxygen, you want to resuscitate. You go through your ABCD of resuscitation, make sure that the airway is patent, make sure that, they say now it's more of CAB, you check the circulation, check the airways, check the breathing, make sure you secure an IV access, but not for IV fluid, because if you give patient with heart failure IV fluid, you're going to worsen their condition. So you check their oxygen saturation. If it's low, you want to put them on oxygen. If it's less than 90%, studies have not shown any benefit for oxygen in patients that have saturation more than 90%. So you want to place them on oxygen. You want to start them on loop diuretics, as this would help to reduce the congestion in the lungs and make them less breathless. So loop diuretics like torsemide or furosemide could be used in the acute setting, and doses as high as 100 milligrams of furosemide to 120 milligrams of furosemide could be used. Even torsemide up to 80 to 100 could be used. Also, you want to, if they're acute pulmonary edema, you may want to use morphine to reduce anxiety. Okay. Other medications you want to add are things like aldactone, that's spironolactone, or the potassium-sparing diuretics, which would include aldactone and eplerenone, commonly available in our environment. You want to use that. Also, you want to give other medications that could help survival. So usually, this is a very important state in the management of heart failure. Drugs that improve survival of heart failure. These drugs would include angiotensin converting enzymes or angiotensin receptor blockers. Also, drugs like beta blockers, cardioselective beta blockers. There are newer drugs like the angiotensin receptor blocker, neprilysin inhibitor. And then recently we have the SGLT2 inhibitor, so that's sodium glucose transporter 2 inhibitor. These are some of the drugs that are indicated for improvement of survival in patients with heart failure. So there are drugs that improve morbidity. These are drugs like the loop diuretics, and then drugs that improve mortality, which include, like I mentioned before, the ACI inhibitors, ARBs, angiotensin receptor blockers, neprilysin inhibitor, that's the ARNI, which is sacubitril. You also drugs like beta blockers, cardioselective beta blockers, and also the aldosterone antagonists have also been known to improve mortality. Okay, so for patients that meet the criteria, you may want to use device therapy for them. Patients that have severe left ventricular systolic dysfunction, they can use what a left ventricular assist device in also as a bridge to cardiac transplant. Also, some patients will benefit from what we call cardiac resynchronization therapy. That's right. For those are patients that on ECG they have a wide QRS complex. Okay, so they may benefit from cardiac resynchronization therapy, and also for patients that are at risk of sudden cardiac death, they may have an implantable cardiovascular defibrillator put in place while they are waiting for heart transplant. So the final treatment for heart failure is also cardiac transplant, as when the heart has failed and the patient is not responding to medical treatment again. Okay, so these are some of the drugs and their doses used in heart failure. So we talked about the cardioselective beta blockers, and so some of the cardioselective beta blockers include bisoprolol, carvedilol, metoprolol, nebivolol. So those are some of the cardioselective beta blockers. So some other beta blockers like propranolol, atenolol are not used. They are not indicated for use in heart failure. So this must be noted. Then sometimes patients with heart failure may present with high blood pressure. One of the drugs we don't use are the fast-acting non-dihydropyridine calcium channel blockers, like nifedipine. You don't use them in heart failure. We can use amlodipine in conjunction with our ACIs when we have elevated blood pressure. So those are one of the things that we don't use. We don't use nifedipine in heart failure. So sometimes we combine the furosemide with thiazide-like diuretics like metholazone. Okay, so they are also very useful in heart failure patients. All right. Because these are still some of the drugs, like the cardiac glycosides, digoxin. Digoxin helps to increase contractility of the heart function. Also, its function is more for improving morbidity. It has not been shown to increase mortality in patients with heart failure. Okay, and then you have other drugs like the nitrates, like azoxystrobate dinitrate and hydralazine. They are used in combination. They can be used in combination in patients with heart failure. And usually the blood pressure of these patients will be above 110 over 70 before you can use this medication. The combination of azoxystrobate dinitrate and hydralazine have also been shown to improve mortality in patients with heart failure. So it's also, this combination has also been shown to improve mortality in patients with heart failure. We also have phonic current channel blocker. This is one of the newer drugs used for heart failure. It's also been known to improve mortality. This is ivabradine. It's a phonic current channel blocker. It's actually indicated in patients that beta blockers have been started, yet you have reached your maximum tolerated dose of beta blockers, but yet to achieve the target heart rate of less than 70 beats per minute. So when you put patients on beta blocker, your target heart rate is less than 70 beats per minute. So if you have not achieved it, you could add ivabradine for the patient. And also in patients that cannot tolerate beta blockers, ivabradine is indicated. All right, so I think with that, we have come to the end of the heart failure lecture. We'll take questions. Any questions?
I don't have any questions, sir. I understood everything you said.
Okay. Okay, so no clarifications. We are all good. Okay, so let me ask a question now.
Please, before you, sorry, I'm so sorry. I just realized something. You're talking about nifedipine and why we don't use it for heart failure, but I'm not really clear on the why we don't use it for heart failure.
Okay, nifedipine is a fast-acting calcium channel blocker, and it's been found to worsen the condition of patients with heart failure. So it's not recommended for use in heart failure. Yes.
Okay.
So that's
because it worsens the condition.
Sorry?
Because it worsens the condition of the patients, right?
The condition of the patient, so it's not recommended for use.
Oh.
Yeah.
Okay, thank you.
Yeah. Okay, so let me ask a question. What are the cardioselective beta blockers? Dr. Eros. Okay, Dr. Afolabi, do you want to answer?
Cardioselective.
Yes,
Oh.
cardioselective beta blockers. So the beta blockers we can use in heart failure patients.
Oh, heart failure.
Yes.
You mentioned them, right?
Yes, I did.
Yeah, that would be this thing. The bisoprolol.
Okay.
And you were hello?
I'm hearing you. Bisoprolol, yes, correct?
Atenolol, can we use that for heart failure?
No. We can't use. We don't use atenolol.
Okay. Then carvedilol.
It's very correct. Yes, carvedilol is correct.
Then nebivolol. Yes.
Nebivolol is correct.
Okay.
Okay. Also metoprolol. Metoprolol is correct, and acebutolol, pindolol. They're all in heart failure.
So all the laws apart from atenolol.
Not all of them apart from atenolol. Atenolol is not used. There are other ones. I will not mention them so that it will not enter your head.
Okay.
Well, these are the ones.
Okay.
All right. Okay, so maybe we should, since there are no questions, we can end the lecture. That the other person that has a
Thank
lecture
you very
can
much.
come on. All right, well done. Thank you.
Okay.